Okay, good evening, everyone. My name's Daniel Gaia. I'm a gastroenterologist at Glasgow Royal Infirmary, and it's my great pleasure tonight to host a question and answer session for the Catherine McEwan Foundation. This is specifically aimed at adults with inflammatory bowel disease, and anyone who knows me professionally knows I am technically useless with this sort of stuff, so apologies if anything goes wrong. I'll be hearing various questions coming into my ear, so if I look a bit vacant, then that's the reason why. Perhaps a wee bit of background about myself. First of all, if I may, so as I said, I'm a gastroenterologist at Glasgow Royal, where I have been over the last 12 years or so. My special interest is inflammatory bowel disease. And it's no great surprise that many of our patients are extremely anxious about their care during the COVID outbreak, and how that's going to affect things. Yes, and I'm being told just now, if you can type any questions you've got underneath your name, that would really help us. So many patients are very concerned, not least how COVID could affect IBD and their care, but also how services may become fragmented as we get pulled to various locations to look after COVID patients. Myself and my colleagues are in the midst of learning how to deal with additional ventilators and CPAP machines to help COVID patients breathe. This is not something we've ever been trained on previously, and thus it's taken us away from our day job, so to speak. Okay. Okay, hello, Shona Johnson. Hello, Beth Turner. Hello, Barry Cook. Hello, all the cooks. Apparently there's several of you. Please get some questions so that I don't have to rabbit on about my background. But I'll keep mumbling on until I get some questions through. I think obviously sources of advice for IBD patients when your service will be thin on the ground. Crohn's and Colitis UK have got an excellent and rapidly updated web page which has guidance not only from the British Society of Gastroenterology, but also as of today they have a risk assessment tool in place so that you can punch in your own clinical details and get a result as to your risk status. Now, I believe we've got a question from Jeanette Gardner. Ulcerative, my daughter suffers. Okay, so a lot of patients will be getting letters from various sources telling them that they are in certain risk strategies, depending on what treatments they're on. Now, I think the first thing to say, which should hopefully reassure a lot of patients, these risk categories are hypothetical. We have no evidence that any of these treatments worsens the outcome of COVID, in particular the immunosuppressants and biological agents. In fact, the data we've got thus far actually suggests patients may have a milder course whilst on immunosuppression. So a lot of this is theoretical. Depending on what drugs your daughter is on, she will fall into a certain risk category. The highest risk category, we are recommending shielding, which is essentially self-isolation over the next 3 months. Now, it's near on impossible to do that unless you are in the fortunate position of having a granny flat in your house with separate toileting and cooking facilities. So I think we're all of the knowledge that most patients cannot and will not do this. However, we are erring on the side of caution here, and I and my colleagues make no apologies for doing so. We're trying to keep everyone safe. Strict social distancing should be observed, regular hand washing. But in answer to your question, the risk to your daughter of you being at work is low. I hope that answers it. Okay. So, yeah, I'm being told in my ear I need more questions. So, can you all get typing? As stupid as the questions may sound, I will answer them. Hello, Bev Turner. Apparently, you have asked a question. Thank you. That's right. So, Bev, that's an excellent question. Bev has just asked. She has ulcerative colitis and she is currently flaring, and she's wanted to avoid steroids, and she has asked if steroid enemas would alter her immunity. So if I can tackle the steroid story first, in of the data we've got in patients who have had COVID, now most of this comes from Asia, as you might expect. The risk factors for severe COVID related disease are related to comorbidity, male sex, smoking status, so smokers tend to do worse, and patients who are on NSAIDs, which are aspirin and anti-inflammatory drugs related to aspirin. There is also theoretical concerns about steroids because patients with SARS, which was the respiratory virus, which came from the Far East before COVID, they did worse with steroids, and it also had no effect on the lung illness. So we're trying to avoid systemic steroids in patients, and you'll see from the CCUK guidance and the British Society of Gastroenterology guidance, if you are on 20 milligrams of prednisolone, which is the most commonly prescribed oral steroid, then you fall into the highest risk category. So we're trying to avoid steroids. By the same token, we're trying to avoid flares in all our patients. So in answer to your question, topical steroids are absolutely fine, no problem at all. They would not increase the risk of a severe outcome with COVID. I would probably hasten to add that you're better taking topical mesalazine or 5-amino-salicylic acid, as that has greater efficacy or greater effectiveness in ulcerative colitis than topical steroids. But topical steroids, a bit safer than oral steroids. Oral steroids would be a last resort, but they may be required. So, if you're deteriorating, then please do contact your local IBD team. Okay, hello, Karen Donnelly. Thank you for your question. Azathioprine. Okay, so yeah. So you've stopped steroids 3 weeks ago, and you've stopped azathioprine back in December. Do you need to self-isolate? So you stopped the azathioprine in December, and the steroids were stopped 3 weeks ago. Okay. So the honest answer to your question, yeah, you had a bowel resection. So no, you are currently not in any high risk category, so you don't need to self-isolate. However, I would still be practicing enhanced social distancing, strict hand hygiene, etc. Just protect yourself as much as anyone else in the public, but you are not at any specific risk. The azathioprine is out your system and you're off your corticosteroids. And assuming your wound is clean, then you're not at any heightened risk. Hi, Alice Valat. You have said a question. So the question is, how long does prednisolone stay in your system? Well, that's a good question. It depends on what dose you're taking. Okay, so you're awaiting your biopsy results, and you've been told to start prednisolone. So I think if you've been told to start prednisolone and it's not, they haven't stipulated which dose, then I would err on the side of caution and take a dose of 20 milligrams or below. I think the key thing is steroids will be required for some patients. We're trying to keep that to a minimum, but patients will flare, and those flares need to be treated. We don't want you becoming sick and hospitalised as an emergency. So while steroids are best avoided, we can't avoid them in all patients. And if your treating clinicians want you to have corticosteroids, then so be it. But you just need to take extra care with the shielding measures as outlined in the CCUK and BSG guidance. Hi, Marie Kelly. Thanks for your question. Yeah, so if you're having a flare, certainly at Glasgow Royal, we are trying to do most consultations remotely, so via teleconsultation, which actually is relatively straightforward. Most facilities now have a complete electronic patient record, so we can see your bloods, we can see stool results, we can obviously chat to you and put a management plan in place without you having to come to hospital. Obviously, if you're particularly unwell, then we would admit you as planned. But as you say, standard routine outpatient consultations have stopped for the present time. Can I read that? Yes. Right. Question from Amy Halliday. I'm on adalimumab once every 2 weeks. I know as possible in a special needs school. So if you're able to work remotely and are being provided with remote access and can do some online work, then that would be the most sensible and safest strategy, in my humble opinion. Okay, another question coming from Tegan McVeigh. Hello, Tegan. If someone with Crohn's or colitis gets COVID, are they more likely to be more unwell and sick than others that get COVID? So that's an excellent question. The short answer is no, which is good. Overall, no, and that accounts for the large majority of patients. The patients we're most concerned about are those elderly patients with lots of other illnesses, such as heart disease, lung disease, excuse me, and who are on prolonged course of high steroids. These patients may have a more severe attack, but the large majority are at the same risk of everyone in the population, including me. Right, I have another question from Ruth Wilson. Do you know if all Glasgow hospitals have sent letters out to Crohn's patients on Amgevita? As my son hadn't received one yet. He's an adult under Gartnavel General. Thank you. I guess every single unit is doing matters slightly differently, so there's no rules. We are finding our feet with this crisis and firefighting to a certain degree. You may be simply directed to the Crohn's and colitis website. We at Glasgow Royal, we've elected to letter all our patients to highlight the risk, categorization and the isolation advice. But that is not across the board, certainly within Scotland. Okay, they're coming in thick and fast. Now, Callum Muirhead, thank you for your question. Hello, Callum. I have ulcerative colitis and I'm on adalimumab medication along with azathioprine and have very mild asthma. Should I be shielding or social distancing? Right, well, that's a good question. I guess, as you've probably got the gist of my opinion by now, Callum, I think we need to be pragmatic here. You will be, at slightly higher risk with your airways disease. You're on, I think you said, adalimumab and azathioprine. So I would be advising shielding, and if that's not possible, then certainly enhance social distancing, keep yourself as safe as possible, certainly working remotely, avoiding any crowded spaces, etc. Right, Aileen Haverstock, hello. No, Alison Haverstock, hello, Alison. I'm currently on azathioprine, adalimumab, Pentasa, and received a letter from NHS to shield for 3 months. Is there any harm in going for a walk on my own, staying away from everyone? Short answer to that is no. I think going out for a walk is incredibly important, mentally and physically. You just need to be incredibly careful. and keep yourself safe. We, as I've said, in our unit, we are overcalling it. We are getting more patients to Shield than national guidance, but we took that decision well before the national guidance was actually decided, and we make no apologies for doing so. It's just, we know that even if we recommend shielding or self-isolation, majority of patients cannot and will not do it. Hello, Susie Henley Gill. Thank you for your question. My Crohn's is starting to come under control. I'm on azathioprine and infliximab. I have endometriosis, pancreas issues, chronic sinusitis, and susceptible to lung infections. Should I be shielding? Yeah, I mean, the answer is I would probably advise you are shielding if you're having chronic lung infections and sinusitis and you're on dual immunosuppression. Then I would certainly err on the side of caution, shielding where at all possible. And if that's not feasible, then enhanced social distancing. As I said, these are not absolutes. This is just our guidance in the absence of any firm evidence we've got thus far. I should also highlight at this point that the World International Organization for the Study of Inflammatory Bowel Disease is collecting data on all COVID patients who also have inflammatory bowel disease. And it's called the Secure IBD database. And if you can punch down this website, if you're interested in looking, www.covidibd.org will give you information on everyone around the world who has been added to this database, who has a form of inflammatory bowel disease and has tested positive for COVID. And you can see most of the data as of yesterday when I looked is very reassuring in terms of outcome. Right, next one is Rachel Solis. Hello, Rachel. I'm on fortnightly adalimumab. Am I right in thinking this is moderate risk as government site says vulnerable group? Currently 12-week shielding. I'm finding a lot of conflicting advice. Any advice I'd be grateful for. Yes, Rachel, the advice is conflicting, and it's difficult to I can't make any apologies for that because these are not absolutes. We're working on our feet here, and nobody really knows the outcome. This is a new disease. We don't know the natural history of it, but the early signals are pretty reassuring in terms of inflammatory bowel disease. And on a single agent such as adalimumab, there are no safety signals. Enhanced social distancing would be the UK-wide guidance. If you're able to isolate, then all to the good. Okay, right. Apparently loads of questions coming, but I'm getting tired, but I'm doing okay. Right, Katie Wilson. My son is shielding due to Crohn's and asthma. Finished high-dose steroids in January. He's due his next infusion in 3 weeks. Very worried about going out. I've posted already, but can't see it, so I apologise if this is a duplicate. Well, Katie, I haven't seen it, so it's not a duplicate by my count. Right, how do I answer this? Yes, I understand you're going to be concerned about getting your son to his infusion, but the guidance on this is fairly standard, and I think as UK IBD experts, we are all in agreement. Your son should not miss his treatment. The whole point of this is avoiding flares, because if he or she flares, there is a risk of need for prednisolone or corticosteroids, which is bad. There's also a risk of hospitalization, which is bad. So much more exposure to COVID and worse outcomes with that. So getting to infusions can be challenging. We're obviously recommending not taking public transport and strict social distancing whilst you take your son to his infusion appointment, get the infusion, straight home. That's the best advice I can give you just now. Right, okay. Now I've got one here from Emma Higginson-Smith. I'm really struggling to breathe. Is your opinion made worse because I'm having a flare in my... No, it's okay. I can see it. Right, so if you're struggling to breathe, I doubt that's anything to do with a flare. And maybe related to acquisition of COVID or any number of conditions. I think you would be best dealt with by seeing a medical professional. Certainly, being examined, having your temperature taken. I wouldn't necessarily ascribe breathlessness to any flare of your inflammatory bowel disease. No, that's all right. We're just waiting for the next one to come in. Okay. From Nicola Cushley. Hello, Nicola. Nick Cushley, sorry. Hello, I'd like to ask, as a single parent with 3 children and on DMARDs and a biologic also, and having asthma, and should my children be shielding with me? It's a very good question, Nick. I suspect it will be extremely difficult for your children to shield completely. I think you need to be pragmatic. The kids need some time outside. As long as you're being as sensible as you can in terms of hand hygiene, both you and the kids, trying to keep social distancing in place. I think that's as pragmatic as you have to be. I don't know what ages the kids are, but presumably they need you to look after them and be some form of support. So I totally understand that. Hayley Riley. Hello, Hayley. Hi, Dan. I'm on mercaptopurine. Can you please advise if I should be shielding or social distancing? Thank you. So we've already covered this a few times, but it's confusing. I'm happy to go over it again. So the UK guidance for patients on azathioprine or mercaptopurine is strict social distancing. At Glasgow Royal, we have at the outset of this outbreak, we had written to all our patients on thiopurine suggesting shielding or social isolation. The terms tend to be used interchangeably. I think you need to be pragmatic about it and safe. And if you can practice shielding and social isolation, you should. If you're able to work from home, you should. And if that's not possible, then strict social distancing. Shauna Kelly. Hello, Shauna. Thank you for your question. I'm due to go to the Queen Elizabeth for vedolizumab infusion next Wednesday. Will all infusions be getting moved from there? That's a good question. I don't know. And the reason I don't know is because I honestly don't know what's going to happen at Glasgow Royal, let alone the Queen Elizabeth. This is a very, very strange time, and as you probably heard, there are advanced stages of planning to open up a field hospital at the SEC, and presumably there will have to be some gastroenterology cover for that. So services are going to be moved, doctors are going to be moved, nurses are going to be moved, but I think we've all got agreement that infusions and treatments to keep patients with Crohn's disease and colitis must continue, to keep patients in remission, to keep them off steroids, and to keep them out of hospital. So it's going to be a stressful time for you, for me, for everyone involved in inflammatory bowel disease care, and nobody is immune to that. Okay, Stacey, I've just had my 3rd surgery 7 months ago. I have perianal Crohn's disease. I'm now having to look after my wound myself, which is very big. District nurses were decided to stay away to protect me more. I have nobody checking my wound. What should I do? That sounds awful, Stacey. I'm sorry to hear that. I guess I'm no expert in wound management, so I'm slightly out of my comfort zone answering that. But I'll have a go on best practice. I think my advice would be to contact the surgeon who undertook the work and see if there was any specific advice they would have. They could maybe do a remote consultation with you. You may be even to do a Skype consultation or a Zoom consultation, which is the platform I'm on now. And that is the limit of my IT knowledge. As I've said earlier, I know nothing more than that. But in order to contact your consultant who did the surgery, please contact their secretary. A lot of the secretaries are off just now, either self-isolating or with COVID, but there should be someone covering he or she. So hopefully you'll make some progress there. Hi, Ryan. Thank you for your question. Does having colitis or Crohn's give patients a higher mortality rate based on what we know right now, or is the risk simply higher due to your chance of hospitalization, steroid use due to these conditions? So very good question, Ryan. So on the data we've got just now, patients with Crohn's and colitis do not have a worse outcome overall if they acquire COVID. The risk is, as I've alluded to, in the elderly comorbid patients who are on high doses of prolonged corticosteroid. But overall, and the data on the Secure IBD website, which I mentioned earlier, is reassuring to date. So I think we can take a lot of encouragement from that. As I said, there is early evidence and some theoretical evidence that patients with inflammatory bowel disease who are on immunosuppressants may actually do better and have a milder COVID than those who are not. So no major signals there. Susie Lynch. Hello, Susie Lynch. I am on Stelara, which is ustekinumab, for those of you who haven't heard of that drug. I'm worried about taking my injection in case I have COVID without symptoms. What do you think I should do? Well, that's fairly straightforward, Susie. You should continue taking your ustekinumab. The strong signal to come out from the COVID working group from the British Society of Gastroenterology was that you should all, across the board, continue taking your treatment. The whole point is we want to keep you in remission, keep you out of hospital, keep you from flaring, and prevent any need for steroids, which is the risk if you come off your meds. So please do not continue taking them. If you develop symptoms of COVID, then that would be entirely different, and we would recommend stopping medicines until you are recovering from that. Amy Gardner, hello. I suffer from ulcerative colitis. I was due to get my vedolizumab infusion. However, I have a slight sore throat, which I believe is nothing too concerning, although I am unsure if I should reschedule or go ahead. So I guess it's a judgment call. So vedolizumab is one of the gut-specific biological agents licensed for inflammatory bowel disease. So it doesn't really affect anything other than activated white blood cells leaving your circulation, going to your gut. So it shouldn't have any effect on COVID. It doesn't sound like you've got classic COVID symptoms. I accept that not everyone does, but it's a persistent cough and a fever are the two sort of discerning features. And if you don't have either, then I personally would recommend not missing out on your treatment, because it's becoming increasingly difficult to facilitate everyone's infusions as nurses go off, get redeployed, are self-isolating for their own reasons. So if your treatment can go ahead, I think you should have it. Yes, absolutely. Someone's asked about websites for patient advice. So the CCUK website is excellent. If you punch that into Google, CCUK, which is Crohn's and colitis, they have excellent patient-specific information, and most of it is written by clinicians in the UK. The clinical information is, so it's very, very trustworthy. As I said, I've mentioned the Secure IBD website, which gives information on all the cases collected thus far who have inflammatory bowel disease around the world and have acquired COVID. So that's it's covidibd.org. Christina Johnson, hello, Christina. Does IBD itself increase your risk separate to that of the medications? I've read that people who are dying are having an inflammatory response caused by immune system overreaction. Is this more likely with inflammatory bowel disease? So no, I think the evidence we have from China, the evidence we have from the Secure IBD database, and the evidence we have locally in the midst of this COVID pandemic is that we are not seeing inflammatory bowel disease patients flaring or coming into hospital, which is excellent, because we would struggle with that for all the reasons I've alluded to. Laura Martin, I just need that lifted up just slightly. Perfect. Laura Martin, Should we continue to get our bloods checked with GP, usually every 2 months and due soon? That's a very good question, Laura. And I think locally within Glasgow, we've taken a very pragmatic view on that. If you are a stable patient, you're well, you're in remission, and you have your bloods done routinely every 3 months, then the risk-benefit ratio would probably favour in you not having them just now. Your GP practices, are likely to be more likely a source of COVID than a benefit of you in getting your bloods checked. However, if you had any symptoms, any fever, etc., that would be a different story. But many GP practices have contacted us to say, is it okay if we do the bloods in 6 months rather than 3 months? Which I think, to be honest, is very sensible if you're well. Yes. Okay, so I'm being asked to ask everyone who is tuned in, if you who maybe typed in a question previously that I have not answered, can you type it in again? Because apparently it goes on a run and then it disappears and then we can't find it again. So, right, Bernie McGrath. Hello, Bernie. How does blood pressure have to be how high? Sorry, how high does blood pressure have to be to increase the risk? Is the 8-weekly pre-infliximab steroid a risk? Okay. No, I understand your question, Bernie. So your some patients get intravenous steroid before infliximab. That is not the sort of regular corticosteroid which increases the risk. That is a steroid to reduce the chances of you having an immune reaction to the infliximab. So that does not count. That is not like taking daily prednisolone. So I would not be concerned about that. How high does blood pressure have to be? Well, I think if you are being treated for chronic hypertension by your GP or in secondary care with a cardiologist, then it is a risk category because it adds, you have an excess of comorbidity. I wouldn't be didactic about what blood pressure you need to have to be at higher risk. If someone has chosen to treat your blood pressure, then you have high blood pressure in the risk matrix on the CCUK website. Hope that makes sense. Jane Margaret, what is enhanced or stringent social distancing versus shielding, please? That's an excellent question. And I guess none of us knew this until the government guidance came out. So shielding is a term which appeared about a week ago from the UK government when they put us in so-called lockdown. And it's used interchangeably with self-isolation. I think the government, Boris Johnson's spin doctors felt that shielding was a more dynamic and proactive term rather than self-isolation. But they are the same thing. It essentially means you are shielding yourself from all others. You are living in a separate part of the house with separate bedroom, separate washing facilities, separate cooking facilities, etc. Shielding, self-isolation, same thing. Enhanced social distancing is really following all the government advice in terms of 2 meters, no contact with large groups, etc., working from home, hand hygiene, etc. Yeah, so at this point, I have to plug both the Catherine McEwan Foundation and my good friend and colleague, Professor Richard Russell, who is going to be doing this same chat for our paediatric patients, so 16 and under. He will be doing it at the same time via the Catherine McEwan Facebook page, 7 till 8. Again, he is a paediatrician. He is not as smart nor as good looking as me, but he will do his best to answer the questions. And if anyone wants to maybe message him tomorrow night to tell him I said that, I would be most comfortable with that. Right. Andy Lawson. Hello, Andy Lawson. My daughter has ulcerative colitis. She's on azathioprine and 5-aminosalicylic acids. A condition of her meds is that she has to have her bloods done every 3 months at a blood centre. Is it safer to take her for these? The short answer is yes, it is safe to take her for these. But if your daughter has been stable for a number of months, stroke years, without any problem with her bloods, then a pragmatic view would be to lengthen the period of monitoring out, from 3 months to 6 months, when hopefully we're over the worst of the pandemic. I obviously don't know if your daughter's bloods have been stable. If there have been issues with her bloods, for example, her white count being low, then I would still stick to the 3 months unless you're told otherwise. But some GPs are automatically pushing the gap further out to 6 months, but others are calling patients routinely. Stacey Johnson, are people who are shielding to stay indoors and not to go outside at all, for example, to exercise? Yes, strictly they are, and yeah, that is part of the guidance. I think if you are able to exercise but not and go outside but not come into contact with anyone, then I would encourage you to do so, both for your physical and mental well-being. I know how much I struggle with being cooped in the house with 2 kids, a dog, and a wife, and I have total sympathy for you. John Curry, hello, John. Is there any known shortages of medications, and is the medication still okay to be posted out, i.e. Stelara, posted out every 8 weeks? It's okay, I think I got that, yeah. So medication shortages, the main one we've heard of is azathioprine, which many of you will be on, and there is apparently a UK national shortage of this being delivered. There are various strategies to combat this. There is a liquid form of azathioprine, which can be substituted. Also, there is a sister drug of azathioprine, which is called mercaptopurine, which you normally take at roughly half the dose of azathioprine. So these are options if your supply were to be interrupted, and your local IBD team would be a source of advice in that regard. In terms of the ustekinumab, the Stelara that you're on, then I've not heard of any issues in terms of shortage of drugs at this juncture. Rehannan Sharp, hello, Rehannan Sharp. I have Crohn's disease and it's active. I'm currently in a flare, but have been on steroids since last year. I was introduced to azathioprine, but didn't agree with me. But I had an appointment with my gastroenterologist 2 weeks ago, but decided it's unsafe to start me on new immunosuppressants due to COVID-19. Is there anything else I can do for myself at home? I'm sorry to hear that. I mean, no, there's nothing you can do yourself. I think being on long-term steroids is the riskiest of all the options. And whilst starting an oral immunosuppressant is not sensible just now, the reason being they take several weeks or months to work. I personally, not knowing any of your past history, would think due consideration should be given to starting you on a biological agent for your colitis. These work faster and potentially would allow you to come off corticosteroids quicker. And furthermore, we've had no safety signals of any of the biologicals causing COVID-related harm, whereas there are significant concerns with steroids, which is what you're on just now. So that's my thought. Hope that helped. Helen Carmichael, just need that lower slide. Perfect. Husband just off steroids, which he was on long term over 8 years for Crohn's. Had heart attack and stent inserted last year. Now has heart failure. Should he be shielded? Worried he has flare due to anxiety. So, Ellen, he's obviously at high risk in terms of comorbidity in view of the heart failure and ischemic heart disease. If he's off corticosteroids, then that's good and lowers the risk. I guess my concern would be what is he on to prevent him flaring, and that would be a discussion between him and his local GI team. But purely in terms of his medical therapy and his colitis, he wouldn't be at high risk unless he was having active symptoms just now. If he was having active symptoms just now, then he should indeed be shielding and contacting his local IBD team for advice on treatment. Deborah Fleming, hello Deborah. I'm a staff nurse currently self-isolating. I contacted NHS HR today and they've asked me to return to work with risk assessment having been carried out. I have UC on adalimumab and azathioprine. Unsure if this is safe for me to work at a busy outpatient clinic. Can you please advise? Yeah, I mean, my personal thoughts would be that it's near on impossible for you to be stringently self-distancing and safe to work. I think it's reasonable to have you working remotely if you can get remote access and contribute to healthcare in that way. But personally, I don't think that work as a staff nurse on dual immunosuppression is compatible with national guidance at present. Okay, I think we're up to date with questions. So, okay, I'm to ask for more questions. I don't want any more questions. All right, okay. So apparently we've got another 10 or 15 minutes. So if you do have any questions, then I am happy to answer them. I hope what we've said so far has proved useful. I understand it's a stressful time, but unfortunately nobody is immune. Well, fortunately, maybe for you guys, nobody's immune for this. It is a stressful time for your healthcare team as well. What I was working as last week is not what I'm working as this week, and my job will almost certainly change next week as well. So it's most unnerving. And yes, I'm also to plug Professor Richard Russell. For those of you who've just joined, will be answering all the questions from a pediatric standpoint because he is useless in anyone or anything over 16 years of age. So if you're 16 years and 1 month, he cannot answer it. I'm joking. Of course he can, but his expertise is children with inflammatory disease. Extremely good at that. So he will answer all your questions 7 o'clock tomorrow at the same site. All right, okay. Apparently lots of thanks coming in, which is great. I hope it has been useful. I don't plan on a career doing webcasts. Thank the Lord. Personally, I think I've got a face for radio, but maybe not radio either. Who knows? Yeah. Okay. Okay. So I'm being told that we're up to date with all the questions. So I'll give you a couple of minutes. Any last burning questions which I haven't covered, or else we will end this. And I can thank you for your attention. No. Yeah. We're definitely good. Promise? Yeah. All right. Okay, apparently I'm to ask Lucy Mincher to send in her question again as we're frantically trying to locate it, and then I can address it. So Lucy Mincher, if you are still on, fire your question in again, please. Lots of messages coming in saying thank you. I appreciate the thanks. Thank you so much. Please all stay safe. As I said, we're all in this together, I'm afraid. Nobody is immune. New disease, no immunity. Just yes. Okay, so just a comment there about asking how my work has changed since the COVID pandemic started within Scotland. So all our outpatient clinics, I used to do 2 a week. Well, I used to, up until 2 weeks ago, I did 2 a week. They have now all been cancelled. I used to do an endoscopy list, so that's endoscopies and colonoscopies. That has all been cancelled. So the only endoscopy being done within the NHS in the UK is emergency endoscopy in the setting of patients bringing up blood or passing blood, or perhaps being unable to swallow due to a blockage. Otherwise, all routine endoscopy has stopped. So we are, assessing inflammatory bowel disease much more remotely. The other thing I should add is, for any of you who've handed in fecal calprotectins in the past, that's a common test we do for remote monitoring of disease activity. That test has currently been withdrawn from Greater Glasgow and Clyde Health Board because the virus theoretically is shed in stool, and we need to protect the lab technicians. So that may come online later in this pandemic, but it's currently offline. So if you've been asked to hand in a kit, it will not be analysed just now. Right. Samuel O'Donnell, right. Sammy, right. My sister has been referred to a surgeon for a proctocolectomy, as no biological meds are working. We are worried that she is going to get a flare and maybe need emergency surgery. How safe is it to have surgery during this pandemic? And would she get proper aftercare if she did with the district nurses? It's a very good question, and I understand your concern. District nurse service, if I can answer that first, is going to be impacted in the setting of a COVID-19 pandemic, as is every nursing service. Lots of nurses are off either with COVID or self-isolating because someone at home has COVID. So I can't make any guarantees in that regard. In terms of surgery, it's much better being done electively rather than an emergency. In all outcomes for inflammatory bowel disease, patients who have an emergency surgery do worse than patients who have elective surgery. So if it's at all possible to get, I think it was your sister, through to the point of having an elective operation, then that is preferable. Stacey Elizabeth, hi Stacey. I'm a nurse and I'm having a flare at the moment. My recent appointment was cancelled and my manager has advised self-isolation. Can you advise on this, as guidance is mixed? So I guess it depends what meds you're on just now, Stacey. So if you've got active disease and you're on steroids over a dose of 20 milligrams of prednisolone, then you should be self-isolating. If you've got active disease and you're on any other disease-modifying therapy, stronger than mesalazine, stronger than 5-ASA, then you should be self-isolating. So it sort of depends on where you are in the risk matrix. But if you have a look on the CCUK website, there is now a patient assessment tool, so you can find your own risk and get your own advice directly from Crohn's and Colitis UK. Hope that helps. Okay. Right. So I'm okay. I'm being told that we've answered all the questions. Thank you so much for posting them in. You have been amazing. I'd like to thank. Wait a minute. Sorry, I'm being told that a question is coming in from. Here we go. Right, from Lucy. Lucy Mincher. Hello, Lucy. I have ulcerative colitis and I'm on azathioprine and Pentasa, but have been having issues with low white blood cells recently. I have been having to go for quite a few blood tests along with 3-monthly appointments. Will these be going ahead? Also, if we have an issue with our IBD, do we still contact our nurses regarding it? So the answer, Lucy, is yes and yes. You know, I think if your white blood cell count has been on the low side, then we still need to monitor you because azathioprine can cause bone marrow suppression, which, if it happens, places you at risk of every infection under the sun, not least COVID, but everything. So we need to monitor that, and the risk-benefit ratio would be in favour of continuing to be monitored. yes, your local IBD service should still be in place, I hope, not knowing where you're looked after, but that should be your first port of call. And GPs are still working just now. They are encouraging people to stay away from the practice, but the GP contacts I've had this week, they are actually seeing a lot less activity because patients are staying away. So I think you may be surprised that GP, who are normally overrun with patients, are not so at the present time. Gabe Laramore, hello. Lara Moore. Oh, it just moved up there, the question. That's okay. Right. Sorry, it's moved again. Sorry. I'm a paramedic and I have colitis. I recently switched to vedolizumab and finished azathioprine. There's no question there. I think it might go on. Sorry. Information has been mixed. I'm healthy at the moment, but I've been seeing patients with COVID-19 for 2 weeks. Okay. It's obviously your job is places you at increased risk of acquiring COVID, and from what you've said is not really compatible with government advice and national advice on strict social distancing. It's good that you're keeping well just now, but I would speak to your employers about remote working until this pandemic has passed. Last question. Does sulfasalazine put you at risk? No, it does not. So sulfasalazine is one of the 5 aminosalicylic acid drugs, otherwise known as mesalazines. These are topical drugs, which means they are not absorbed into the bloodstream. They work locally on the colon, and they don't immunosuppress you in any way. So if you respond to them and you're in remission, you have disease at the milder end of the spectrum, and you don't need to stop it, and you're not at any increased risk in terms of immunosuppression and COVID. So I hope that answers all your questions. I think we've covered everything. I guess it leaves me to thank the team at the Catherine McEwan Foundation for asking me to do this. It's been great. My first ever webcast, if that's what it's called. Who knows? I also need to plug Professor Richard Russell, who is going to do this tomorrow night, 7 p.m. to 8 p.m. for the children. And as I've already alluded to, not as smart or as good looking as me. And on that note, I think we can say good night. Thank you all for listening.